Hello, everybody. Thank you for joining another Bananas. Great to see you. We'll wait maybe a few minutes to let a few more people in. Um, Great to see you all. We have some good stuff to discuss. And we'll start by advertising the banana course, which probably, I don't know, probably doesn't need to be advertised for the particular people here. You all know about it, but maybe, we'll post the recording. This is being recorded. We'll post it on YouTube and directly and your radio, so you'll be able to see it. Anyway, the course is in April, 3 day, in person only. Um, we have more information. So you can either scan the QR code or this is the website down below. You could take a look at it, register, spread the word. This is our program. A lot of our faculty are here today. Dodi, Renee, plus all of our NYU faculty. So we're really excited. If you are coming, just like we do today, when we showcases and discuss, we have a session in the evening, 2 of the 3 evenings that we're there, on Monday and Tuesday. Runs Monday through Wednesday. So Monday and Tuesday, we're gonna have evening discussions of basically like this kind of format. We talk, we eat, there is food, there's drinks, and there's tons of good time. So, if you have any questions about any of this, you could reach out to any of us, and we'll help you. Okay. Let's see. Let's go ahead and start. Whoever speak up. So if you're not speaking, mute the mic as you're doing now. Thank you. If not, speak up. Let me know who wants to present first.
Michihiro, I would say. He's the best.
Not yet prepared, but up to you. Yeah. Which you mean that the
Okay.
case report or case study, right?
Yeah, anything. So, okay. So, we'll have you maybe in a bit.
Yeah,
Anybody else?
I will coming and give me just 10 minutes prepare.
Okay.
Yeah.
All
Sorry,
right.
sorry, I didn't mean
Okay.
to.
Uh,
So
let's
maybe
see. Maybe if anybody has a time commitment or something else, needs to leave earlier.
Just Dodi, go ahead.
should I?
Dodi,
Okay.
you're up.
Okay. Let me check and share my screen.
Let me stop the share. Mhm. Okay, I think we're good.
Okay, so can you see my screen and my presentation?
Yes. Yes.
Okay. So this is a case we will have fun discussing a few things. So it's a 62-year-old lady who's a medical doctor with the usual spinal cord symptoms like, strength in the legs and sphincters and all that. And so in October 2024, she has an initial MR. And this is the MR. As you can probably see, you see just, a faint hyperintensity in the conus and the usual things. So after that, she has a CT angio a few weeks later, and now you see much better all the vessels around the spinal cord, and so you know what the problem is. And so obviously you go to a DSA 1 month later, and this is the DSA, and you find something strange, strange, something probably you wouldn't expect in this case, which is a epidural AV fistula at the level of T9, T10. This is the left T9 injection, and this is the right T9 and the right T10. So you can see that there are feeders coming from both sides. And the level below, of course, there is big feeders coming from the artery just below, which is T10. And this same T10 artery will give the Adamkiewicz. So you can see now the spinal cord, the anterior spinal artery, which goes down to the usual. So this is a Dynasty, which is not because it's a Philips machine, so whatever. And which shows that the vein is really an epidural vein. It's inside the spinal canal, and it goes outside. This is the lateral view of the same thing. So here is where this epidural veins connect to the external veins of the spinal cord. I'm sorry, of the spine, then you go down a little bit. So from T9, you go down to L1, and you see another high flow epidural AV fistulas, again, big epidural veins that connect to the paraspinal veins. And of course, in the same region, you can see the feeders coming from the level above T12 and the level below L2, same as you would expect. And from the other side, right L1 and right L2 all join at the level of the epidural vein on the left side at L1. But then more interesting, when you inject right T12, which of course shows again the feeders going to the epidural veins, the level below, you see something strange up there, which at first is considered a pial AVM. We will see that a little bit later. So, of course, there is sometime it's going forward. There is a control MR thinking to have a treatment. And this is the MR, which shows, again, much better the spinal cord, the hyperintensity, edema, and all that, and the vessels. In February, the endovascular treatment was decided to do to sort of reduce or occlude the epidural AV shunts to minimize the flow into the spine and to go later with surgery on the pial AV shunt. We could discuss this procedure, but anyway, this is what was done. So this at T9, as you remember, there was a epidural AV fistula on the left side, and the T10 artery was giving the Adamkiewicz artery. So the decision was to go via a venous route, and coming down from the azygos vein, they would enter the epidural vein and put coils to occlude that vein and hopefully the whole fistula, which, yes, they succeeded in occluding. So now you don't see anymore the shunt into that epidural vein, and you still see, of course, the Adamkiewicz artery. So now we have an MR, knowing that they would go, they needed to go to the lower down fistula, epidural, and this was the MR showing again same thing, vessels and spinal cord edema. And when going to the following step, which is this one, they injected squid into the L1, left L1, with reflux in the 12, dorsal 12 on the same side. And then they injected the right L1 with, again, squid, and the left L2. All this to minimize and to reduce the flow in the high flow fistula which is at L1. Very good. And since they were there, they started to decide to study a little bit better the T12 artery. And again, now you see the T12 artery after the occlusion of the fistula on the left side, but it was the same procedure. And now you see this. You tell me what you think about it, but the idea was that maybe here there was an nidus. Can you see my arrow pointing? Yeah. So you see an arrow here. Sorry, you see a sort of nidus going into a vein. So this was the initial interpretation of this. But then if you follow the feeder to this, okay, maybe I'll show you a little bit turning around. I go back a little bit just to show you how, if you look at it on the side, in the lateral view, you see that it is not really a nidus, but these are vessels around the spinal cord. Okay, I hope you can see that. But at the beginning, this was not really understood or taken care of. But certainly what you can see is that, so you inject the T12, and a branch of this artery is going down into a small tangle of arteries, which afterwards will jump to probably something else, going down again, and then up to this. So this is how it is going. It really doesn't look like an artery all the way up to this tangle of this, let's call it nidus. So where is the AV shunt? Is it here? Is it here? I put these images to show the relationship with the bone. Is it here, down there? Is it there? I'll let you think a little bit. Or is it there? Or is it there? Certainly, this is the usual appearance of a AV shunt, meaning that you have something small which becomes larger, but maybe not. But anyway, it was thought, anyway, they should occlude it. This is the injection through this artery, and you can see that, what you see. And squid is injected, and you reach the, let's call it nidus, and the vein. So here is when you inject the squid, which goes up, 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 up. And here you can see that it goes even into the whatever, this little reticular formation, and then the vein. So very happy. Everybody's happy. Okay, we've done it. She's cured. Let's go. And she has a control MR, which, ouch, there are still vessels there. So what's going on? But then you go back, and it was not so difficult to see, because since the very beginning, it was obvious there was something much lower than what was seen on the angiographies so far. And so maybe something was coming from very low down, which is, this is the original CT angio, which showed very well that there was a vein coming up from the sacrum. Here is the sacrum, and all the way up to, so the usual dural AV fistula of the sacrum. And also, when we injected the so-called AVM, it was obvious that the contrast was diluted once it reached the vein, so something else was around. And so on March 20th, she repeated the DSA, and the fistula was found at the sacral level. Not so difficult to find it. And you can see how it goes up to the conus, and then up to the dorsal level. So this is what really we were looking for. You can really see the veins that were visible on the CT angio. So, okay, this is the time, this is done. What is done? Well, we should do something, of course, and here you can see the vein coming from the sacrum and going up. Okay, the usual thing, nothing strange. So surgery was done on the sacrodural AV fistula. We love surgery on dural AV fistulas, and you can see the clips here, and no more vein. So okay, finally she's cured. She has an MR on July 2025, so a few months later, 3-4 months later, and of course no vessels anymore down below in the lumbar spine, no vessels on the conus. This was pre-surgery, and this is after surgery, pre-surgery. But then you look higher up, and there are still vessels there. So still a few months later, in October, she has a new DSA, and you control everything. So now you can see the coils at T9, the squid at L1, the clips at S1. And finally, you look at everything that was already embolized, and everything is okay, no shunts, nothing anymore. There is still a little bit of shunt at L1, but no intraspinal vessels are visible. But when we inject left T9, this is what we see. So another shunt, another vein coming from where? Well, coming from the T9 level, where the first epidural fistula was occluded with coils. But interesting is the way it goes. This is what we see on AP view. This is what we see on sort of oblique view. So certainly it's a vein. Certainly it's something that shouldn't be there. And so how it goes that from the veins on the epidural space, which was occluded, you have a new vein coming all the way around the dural sac, going down to the lower level, then up to the new fistula and to the new. And this is the lateral view of the same thing, going down and then up. And this kind of tangle is typical of the epidural veins that we can see often, both by injecting the vein and injecting whenever there is a fistula. And interesting also is that this part of the vein coming from the left side to the right side is obviously this vein, which is going around the posterior arch of the vertebra, so in the epidural space. So it's epidural since the beginning, this sort of network of veins going into one vein, going down, all the way down to the lower level, and then up to where? Up to here, where it probably becomes intradural. So this is probably the location of the passage from epidural to intradural. Why I think it's like that, well, we can discuss that, but especially because of the change in caliber and the location, which is typical from where the intradural veins are going into the epidural space. Well, we go forward with this, and again, here is how it was T9 before, a few months before, when it was occluded the epidural fistula, the first one that was occluded with coils, and of course there was nothing visible at the time on the other side. And this is the level where the fistula is. There is nothing coming from the arteries in that location. So she has a second surgery, also in that level, and this is the post-surgery DSA showing that there's nothing anymore. So this lady had one epidural AV shunt at left T9, T10, which was occluded with coils. One epidural AV shunt at left L1, which was occluded with liquids. One extraspinal, I think, shunt at right T12, which was occluded with liquids. One sacral dural AV fistula, which was occluded by surgery, and one epidural AV shunt at right T10, again, occluded with surgery. Why Hydra? Hydra. Hydra is a mythological serpentine lake monster. It had poisonous breath and blood so virulent that even its scent was deadly, but especially for every head chopped off, the Hydra would regrow 2 heads. And the monster is killed by Hercules as the second of his 12 labors. And it became a constellation. Thank you.
Wow, thank you, Dodi. In this one case, you can learn like probably 9/10 of what you need to know about anything spinal.
Exactly.
Okay, any comments, questions?
I mean, there's so much to unpack. I mean, no, leave the presentation so we can go back
Okay,
to some
sorry.
images. One thing, one thing that immediately jumped to me is I love how you decide to fix that epidural, going through the vein. And I think it seems like that was the reason why it was done, was to preserve the Adamkiewicz. But regardless of the Adamkiewicz, that's a good approach. So I was surprised you didn't do also the other epidural fistula that way. So that's one comment. And I mean, you can just answer and we can go from there, because I have other comments.
Yeah. It was not me. Of course, I'm not working anymore, so I just had the chance to jump on this case, and I found it really interesting, and a lot of, as you say, a lot of things we can discuss. So I cannot answer with certainty. Probably they saw there were many arteries also, and small nidus-like arteries, which you could occlude more with injecting a liquid rather than just by occluding the vein. I think so. I'm not sure. Okay, so we can go back to, I don't know, to how it was. So it was this kind of thing here. It might be that you want to occlude also arteries, but they didn't go into the vein with the liquids. So you're right.
Yeah.
And maybe there was also, I think they tried, but there was a problem in finding the road and to get into the vein. So they tried to get there, but they couldn't because, as you can see, there is kind of a knot here. I don't know. So that might also be another explanation.
Now, yeah, another thing, that prospectively, it's such a complex case, so don't take it as a criticism, right? But it's more like, no, in a prospective approach of such a case, what when you look at all these images, you don't see intraspinal outflow, right? So we're assuming that what we're seeing is the main problem causing the intraspinal, the perispinal enlarged veins, but there's no proof on the images, right? None of the initial images show that. Now you show later how that was actually probably mostly related to that dural fistula and maybe by the other epidural. So one thing is that approaching this case from the get-go, there is something that is missing, right? That's what something that you touch upon, and it's not a criticism; it's just something like a way to discuss.
Yeah, when the Adamkiewicz artery was injected, of course, you wait until you hope you can see some veins, but it was not possible. So there were no veins visible injecting the anterior spinal artery, as it happens usually when you have a dural AV fistula of the spine. No, and it's also a typical proof that there is a dural AV fistula, the fact that you don't see the veins when you inject the anterior spinal artery. I don't know if you were.
No, I meant a little different. I meant something. Yes, that's good, and thank you for saying that. No, what I'm saying is that this patient presents with a CTA showing all these perimedullary veins, but the initial angiogram didn't prove those perimedullary veins. So it tells us that there's something that is missing, as you showed later on by the sacral fistula.
Exactly. So, but when you start doing the angiography and you see so much, blood going everywhere,
so much,
you kind of get distracted from the fact.
No, absolutely. And again, that was not, this is a very complex case.
Yeah, Dodi, thank you so much. A very interesting case. And I think even if we may have very rarely this kind of multiple level of the angiogenesis and the dural AVF formations or epidural AVF, but on most of the cases, we may have a sort of epicenter, which is a kind of original place where the angiogenesis is starting. And in my view, your first target was actually most hypervascularity in terms of the forming of the high flow AV shunt. That was epidural. And later you may found that you found actually sacral AV fistula, which is also, for me, looks like secondarily induced because of the initial epicenter, which, epidural and the intradural venous system is a continuously hypertensions, which is an additional trigger to induce multiple level of the AV shunt. So therefore, I think there is a strong relation between them, though the level is a difference. One is T9, one is sacral, one is more upper thoracic and cervical level. But I think that there are some common reasons underlining to form this kind of AV shunt. What do you think?
Thank you, Dodi, for showing this super interesting situation with a patient with multiple dural fistulae, at least two, and together an epidural fistula. I think the key message here is that, tell me if you disagree, but I would say—
I already disagree.
As long as you didn't see what goes inside the spinal veins, I would not treat. I would continue to search until you find what goes to spinal veins, which may be sometimes very challenging, where you need to inject a lot of amount of contrast. Does it come from the epidural fistulas that refluxes secondarily to spinal veins, or is it an associated lesion somewhere else? I mean, you demonstrate very well. By the way, the last control was done at the end of November, so is the Hydra really killed or not? Let's wait for the next bananas for you to tell us.
Okay. Okay, thank you. Yeah, I completely agree with that. We will need to see the follow-ups. But I think there was only one dural AV fistula, the sacral ones. Everything else was epidural, even the very last one. But you're completely right. The big mistake at the beginning was to believe that everything was already seen. Why? Because the so-called PLAVM was thought to be responsible for the veins that were visible on the CT angio on MR, which of course it was not, but it was, the mistake. So a few weeks later, by re-controlling everything, I suggested to do a different DSA to look well down at the level of the iliac arteries.
The
Yes,
other thing I would like to mention is the first embolization was done without being able to diffuse enough in the vein, which is in fact very difficult. So no criticize on this because usually when you push your onyx or whatever kind of dilution you take, it's extremely difficult. And I really believe that from the beginning we should do the efforts of putting two groins, putting a second catheter. I mean, it's a lot of effort, and you don't want to do this, which means you do a left vertebral artery, a left femoral artery. Once the first microcatheter is in place, you have to take the guiding out to bring the second guiding in. But if you do a pressure cooker with a plug made of NBCA, the ability to push more and to get inside the vein is really very much increased, and the chances to get the vein and potentially to avoid step number three would have been potentially increased.
yes, I agree with that. And to answer to Mishikiro, yes, obviously this lady has a different kind of disease than what we usually see. So yes, I agree with you that the hypertension of the whole spinal system, venous spinal system, is probably responsible for all the fistula we see. How and why, I don't have a clear answer, but I don't believe too much in angiogenesis, as you know, but probably just a mechanical higher pressure can induce this kind of shunts. Yeah. I just wanted to, I don't know if I explained what I think is the fistula happening here at the level of T12, the one which
No,
was
you
called,
you you gave us the options of the shunt, and
yeah.
actually that's a nice discussion to have.
Yeah,
Okay.
yeah.
Do you want to go ahead or?
I can take it. I think it's the most inferior point. But it's and which would say, the problem with that is that probably would make that a dural fistula that you're disagreeing with, because you're saying
Yeah.
that it's only one. So it's,
Yeah.
but I'm unsure.
May
So
I know only
yeah.
why only one dual fistula? I mean, there are some patients where it's described or also or described one. I mean, we saw a couple of those patients with two spinal dual fistulae at two different levels. So why not?
No, no, no. I've seen one with three different dural epistles at different
Mhm.
levels. But this one, this is can you see my arrow here?
Mhm.
Okay, this is the typical location and shape and course of a epidural vein. So this is already vein to me, all the way up,
Yeah, yeah, yeah,
coming
it's vain.
from a shunt which is probably here. So
Yeah.
the second here. So this is artery, artery, artery up to the second arrow, and then from then on, you enter the spinal epidural vein going down, 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 and then up, which is the usual course, around the how do you call it, the radicular, the root, and then up to the. So this is all vein to me.
Now, whoever injected didn't think like you, right? Because they
Exactly.
injected all the way up.
Yes, yes, yes. And but to me, this is already, a tangle of veins around the spinal cord, especially because it's around. It's not a glomus-like vessels. That it's going around, so it's up. I hope you could see that in the previous 3D. But this is really typical, no? The going up and down in epidural veins, which is something that we see also in the very last fistula.
I would say the main argument for this is that we don't have a course that follows the route. If
Exactly.
it would be a radicular vein, it should be going up. If it would be a radicular artery, it would be going up also. And the fact that it goes down is a support to what you say.
But
And
going down it can also be a meningeal artery, and then from the most inferior point up would be the vein. So I'm following you, Dodi. I'm not arguing that's
yeah,
but
you can argue, if you
yes,
want. I'm not
right.
going to punch you. But so this is, the typical shape of it, because if it's on the dura,
Yes, this looks like but also the artery is on the dura, right?
no. This is epidural, meaning that it's around the pedicle here of the vertebra, while the dural artery is straight. It's not concave. And we can go back to this also. Oh, boom, 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 boom.
Yeah.
Okay, so here you are just inside, yes, of course. But what I want to say is that here you don't see any change. You don't see
I agree. I agree with you.
the usual reticular formation of the arteries going into the vein when you have a dural AV fistula. So it's just a continuity of a vessel here, and so that's why I think it is. And maybe no, I just want to.
You're right, but you could counter-argue that the visualization of the shunt, which is much more proximal, is also quite difficult to see, just like in spinal fistulae. Here, somewhere where your mouse is, yes.
Yeah.
Probably the shunt is there, but it's hard to see.
No, it is here, but it's
It
not
is.
dural. It's epidural. I mean, this is
Yeah, epidural,
dural.
epidural.
Yeah. So it's a epidural, which is often the case with epidural shunts and fistulas, that you just see a very small, tiny artery going into an epidural vein, and then you see all the veins. Boom,
Yes,
boom.
but honestly, angiographically, it's super difficult to see. I mean, open surgery is very easy. You see if it's epidural or dural. And for us, we presume that it's not above, using a lot of additional arguments, but it's a whole science for us to see it, what is obvious by open surgery.
It's not so obvious by open surgery because they don't see the epidural space. I mean, they usually look inside because that's the vein you have to occlude. It's the one that goes to the spinal cord, which they open the dura, they see the vein coming in, and you don't really know if the vein coming in is coming from an epidural vein or from an arterial shunt at the level. You just see a vein. And that's good for them because they just occlude that and it's finished. So I don't think that even the surgeon can really see this and understand it. But I'm pretty much sure, and I go back to this because I want you to see how down here, I don't know if you can see it, but anyway, I'm sorry to take so much time. But so here is where I think is the shunt. You see my mouse? And
Yes.
then going down, down, down. See, there is typical venous aspect going up. There is typical, and then here where there's kind of missing something is where it enters the dura. So when you are a surgeon, you see this, and you don't know if it's coming from it's coming from something outside, but you don't know if it's an artery or a vein.
Yes, but you see that the first vessel is extradural and not intradural. At least you see this. And this should be the vessel getting down from more above. You see that it's not inside the dura, it's extra. So
Yeah.
you know that it's not at this level.
Okay, so this you don't see going down.
Mhm.
But you only see this going up if you open the dura. Again, you might say that the dural AV fistula is here, but I don't really believe that. I strongly believe the shunt is here, and then everything here is epidural going up and going down, then going up. But anyway, you will have the time to look at it
But
on
I think
YouTube.
one thing though,
You know,
here, in terms of like prospectively understand this is very important though, right? Because
Yeah.
I think here everything went well and so forth, but there was an unnecessary distal injection of squid, right?
Yeah.
That
Yeah.
here, based on our discussion, could have probably been avoided and didn't cause anything, fine. But we know it can cause something sometimes, right?
Absolutely, absolutely, I agree.
I mean, the other thing to emphasize on a technical level is like, just like we were saying, like in the end, everything has to make sense. Like why like the relationship between the vessels and the cord. And if we go, as you were showing, Dodi, like in this injection, where you see unapacified inflow from another source into that common vein, the alarm bell like should go off in the experienced person's head, like, this is not from normal spinal cord. We don't see that usually. So something else is going on. I don't see that from any others. Like I don't, from the injections I have done, I don't see that only from here. Therefore, I must keep looking for another source.
Yeah,
And the other source can be anywhere, right?
yeah,
But
Now,
well, that predicated on the understanding of where the shunt is, right? So if we know that these are like veins joining other veins, then we have to look until we find.
yeah.
Yeah.
And sorry, this is another point of interest. So this is a vein, if it is a vein, entering another vein, which is both of them are arterialized, so-called. So how can a shunt into a vein decide to go into a vein, a draining vein, which is also arterialized? That's also something that we usually say it cannot happen. No, that you have a shunt somewhere which drains into a vein which is already a higher pressure. But
with AVM, it happens all the time, right?
yeah, but yeah, but there is more like of a speed of the flow rather than the pressure in the veins, no? So, but here I don't think it's really speed; it's more pressure in the
It,
spinal cord veins. So,
I think it's just multiple shunts in a person. Like this is the venous system they have, right? They have these
yeah,
cord veins.
yeah,
You have multiple shunts. They have to go somewhere.
okay.
And, they happen to find like finally like this common vein together. Um, I don't
Now,
know. And that's also telling, right? That the congestion is, of course, at the lower segment, right? Like where I think like there's obviously more congestion lower down from
we,
these two shunts.
we
I want
cannot.
to,
Yeah, go ahead.
do I have like 2 minutes, 5 minutes to show a companion case? Because I think
Sure.
we spent a lot of time on this case, but
But no,
we
but
have a
one,
very similar case.
Max, sorry to interrupt. One thing we cannot not talk about the surgery versus endovascular approach for the
Yes, we
sacral
don't have to
fistula.
talk. We know we already talked about it in the chat. Dodie
All
loves
right, fine.
surgery. We love endovascular. Whatever, like especially in this whatever. Yeah, forget it.
All right,
So
fine. Go
somebody
ahead.
asked, like, yes. Well, I think, right? I don't know. I'm not being like
I've not
dismissive or
followed
anything.
the chat, so I don't know what it was said,
No,
but
in the chat, the question is like, why not do endovascular for the sacrum? My
okay.
answer was, speaking for you, Dodi, that you
Thank
love
you.
surgery, that we would
Yeah.
have done endovascular, you would have done, so you did surgery.
Okay.
Uh, but I
Correct.
don't know.
Correct. Correct.
Uh,
Absolutely.
let me show this thing here. Um, let me show this case. Uh, uh, okay, can you see this? It's very quick. It's a super complex case, but it's like the same point because this is also a woman. It's actually a woman in her 60s. She originally presented with a sigmoid dural fistula that was closed. Um, and she was having all these leg problems, right? The typical. And this is a very probably similar genetic condition. Multiple shunts, like we're not going to spend time on this. This is like insane. But essentially, similar, like epidural, like extradural, like shunts everywhere, like this, whatever, like crazy stuff. Here's anterior spinal, very hard to see because of the shunt, but indeed that's where it's there. And so cone, like, we're doing all these things, uh, like this, right? But bottom line is again, like, why is the cord congested? Like that's again, like going back to what Dodi was saying, like all of this stuff, but like, where is the target? What Renee said, like, let's find like where the hell is the target? So after we embolized stuff and we did a lot of cone beam to work out where the danger points are, finally, after all of this, you see the shunt. Because in our case, it wasn't multiple shunts, it was one shunt. It's just very, very hard to see. After the embolization, I think we were able to, it's an epidural fistula. This is the pocket, and that's the congestion. And actually, we ended up with like more pictures like this. We could not close it. I tried to push whatever, and I couldn't close it from endovascular perspective. So operation, coils, closing. This is the typical, like reduced in the end, all of this reduced to what we know, which is this big vein, right? That you see surgically and closed. Basically, I just want to show this as like a quick companion case because I think it's a similar kind of disease, similar sort of thing.
Absolutely. And to give support to what you say, it's very difficult to close the junction to the radicular vein and then to the spinal veins because you first have to fill the epidural venous lakes and you have to be able to continue to further inject to the veins until it goes at the level of the junction with the radicular vein. And this, the chance for it to work is difficult.
Yeah. Renee, there was a question for you about pressure cooker in the spine. If you can talk a touch more about like the technique.
Yes, absolutely. We do this for spinal dural fistulae. I mean, the principle of treating a spinal dural fistula is not complicated, but to reach the goal is difficult because the embolic agent must reach the vein. And how to make it reach the vein? If you rely on a single catheter, on a push and plug technique, it's random, and the chance to get it is probably not higher than 60 or 70%. Probably somehow higher with Scepter Mini. But what we do usually in all patients is you first need to have a stable catheter inside the intercostal or lumbar artery, which is quite often the most difficult stuff to do because there are no really good stable catheters. And once the first is in place, that you navigate with your microcatheter, then this catheter, which is placed inside the intercostal or lumbar, is taken down, leaving the microcatheter in place. And then from the other groin, you access with another catheter, which is usually, I think, RDC or any unusual catheter. You get selectively to the intercostal or lumbar artery, place a second catheter in order to inject proximally high concentrated NBCA. And then from the distal one, you can inject whatever you want, usually high diluted NBCA, which enables to get to the vein. I'm not sure whether it was so clear, but I hope so.
Thank you. Thank
So,
you.
Maxim, can I show that just one angiography or two angiography?
Of course. Yes.
Okay. I hope you got it.
Yeah, we can see.
Okay, wait. Here, because there are some technical questions and how to make it spinal angiography. And you know that isocenter is here. So usually this isocenter is focused on our cranium, but our spinal cord is more lower in terms of the inclination with the table. So we need additional mattress, so thick mattress, and adjusting to the level of the spinal cord. The region of interest should be focused on the isocenter of the cone beam CT. Then you will get this kind of, this is a typical dural AVF, and the caliber changes are, as Dodi explained, that the sudden caliber change is indicating the shunt point in the level. And interesting to say that Dodi also showing that somehow plexiform or glomerulus-like morphology which is for me is the initial foot veins, and here is a secondarily dilating of the pial venous systems, and here is the mainstream of the maybe you don't see that my laser pointer, so I will.
Yeah, we see your pointer. We see your pointer.
Okay. So here the caliber change and this kind of glomerulus-like changes are really resembling that as exactly did though showed this kind of configuration. So that is just I want to share that if we could have a high resolution cone beam CT in relation with the epidural venous plexuses and mainstream of the radiculomeningeal artery and the radiculomeningeal system. And here is the posterior spinal artery also partially visible. That's it.
Okay. Michihiro, thank you so much.
Michihiro,
And then the other
why-
things,
Beautiful, beautiful.
just to
why
show,
you cannot just raise the table?
Because isocenter is usually focused on the head, right? And in the Phillips machine, spinal cord, especially spinal canal, is most lower part, which usually isocenter cannot adjust it. So even the highest level of the operation table, but spinal cord is still lower than isocenter. Therefore, we put additional mattress in order to adjust and focus on the isocenter and the region of interest, which is spinal cord. So that is one technical point. Yeah.
Okay, thank you.
and just to mention for everybody else, this is like the attention to detail is tremendous up to this point, but it starts with like the basics, which is general anesthesia, paralysis, pharmacologic paralysis, breath hold during the acquisition of the images, raising up the hands if the lesion is where the hands, raising of the hands would help. All of this stuff has to be done. Otherwise, like, it doesn't work.
Appropriate contrast injection,
Yes. Sure.
the right amount of contrast for the right amount of.
We do have, like, I'll put in a plug for neuroangio. In the chat discussion, there's a link to a section that we're building on cone beam CT, both like Dynavasa, whatever, like all kinds of cone beam CT, different machines. So there's information there about how to do it. So some people, for those of you who are interested, go and see, and practice how to do it. Anything for bowel paralysis, Mohammed? Yeah, sometimes. So for 2D, yeah, you can give glucagon. Glucagon lasts 1 milligram of glucagon. It'll last you about 30 minutes. If the bowel is not asleep, that helps. You can give up to like whatever. You can repeat like 2 or 3 times. Okay, any other comments about Dodi's presentation? Fantastic case. Thank you so much. I think Renee has a companion case or like a spinal case to show in that venue.
Okay. So yes, I just found Dodi's presentation super interesting, and I wonder whether we should not continue on spinal. So I switched to share with you this patient here who had some bleeding 5 years earlier with a diagnosis of spinal AVM. He's doing quite fine. He has almost no deficit. He had a couple of angios and a bit of something was done, but not really much. I don't know exactly what. And I'll show you the angio when we saw him. Here you can see the right vertebral artery. On AP, you see 2 arteries getting down. On lateral, can you see my mouse?
Yes.
Yes. Okay, on lateral, you see here anteriorly can only be an arterial spinal artery. Posteriorly is a posterior spinal artery. And then you look at the left side. The left side, you see also 2 vessels. So the anterior spinal artery is the same one. The posterior spinal artery is another one. Both getting to that same lesion, with a vein which seems to make a kind of U-turn in the beginning, then goes up, is not that straight. And then from T4 left, there is an artery which on the lateral view here, shoulders are a problem, but we cannot take his arms away. So we see that it's the anterior spinal that gives a lot of things here, getting to the shunts. And then we see the right T4, where it just show what's going inside. And we see here this vessel before is not completely straight, but somehow it looks navigable. And then it arrives here, that artery arrives directly within the vein. And then you see the rest of the vein that makes first that U-turn, and then that goes somewhere up. So, and then there's another posterior spinal coming from below, from T6 left, which gives some indirect stuff, which is not really meaningful. So, what to do here? One artery seems to be navigable, which is T4 right, and indeed it's possible to get inside. So you see that the first microcatheter has been brought in, and the artery has a quite large diameter, and then we're at the level of this artery before it goes directly to the vein, and indeed the catheter can be brought inside the vein. With the question, how greedy are we? Do we want to just occlude here, or do we want to cure that stuff? And it's a difficult question because, I mean, the patient is doing quite fine. Does 6D help? We were on our old machine. So this is a 14-year-old Artis Z, which is very good. You see, even after all that time where we can do the fusion of 2, 3D. So these are, I would say, the commercial pictures that are very fancy to see, but they don't explain so much. But at least you see that the selective injection through the selective here microcatheter and T4 right shows that macro shunt. I call it a macro shunt when the catheter can be brought to the vein. And then we see the left where we have both the posterior and the anterior that somewhere come to the same point. And here now we have two catheters with the idea to potentially do more, but how much do we understand? And again, how do we understand the network of arteries getting there? And here are some pictures where I'm not sure to understand what is each vessel. And this is a striking picture, so let me share to you the MPR. So the Coro views on MPR, which are here. So in in orange, we have the injection through the microcatheter. In white, through the left VA. And we see that vein here that goes down. And if we go to the origin of the vein, which is here, we see this, but we see this here. Is this a vein or is this an artery? And the more I follow here, the more I find that here are very tiny vessels. So our conclusion when looking at this picture is this is indeed a perimedullary fistula. It's mainly fed by a posterior spinal artery with a macroshunt. And we find those macroshunts quite often in there, but we never really were able to understand how the venous architecture is. And here's another vein with another shunt, which is somehow dissociated. So is it the vein that is so much enlarged that the both pointer shunts came apart, potentially? But at least we see something here and something there. And this here, please keep this in mind. And then we see then the remaining ascending vein that makes usual U-turns, and which is the reason not to try to go through the vein, because anyway, we've got access to the vein from the artery. So we don't need to navigate through the vein. So how much to occlude the vein? By understanding this, it gives you an idea how much to continue, because at some point, It's scary whenever you continue to inject. If you would inject retrogradely from vein to arteries, if you occlude all those arteries, then he'll really be in trouble if you create so much ischemia. So here we're in place, and I'm wondering whether how I could reduce the flow. And this is here the vein I was just pointing out. I think that when we look at these images, there is no doubt that this can only be a vein. Here are the arteries, here is the shunt, and this is a vein. And I think that without this type of imaging, even if we see this on the DSA, the understanding is much more difficult. But this here gives us this type of understanding. So,
May I stop?
sorry?
Sorry. May I
Yeah.
stop you here just 1 second? Go back to the image because you are probably right, but I don't think we have the proof of what you're saying because this patient had already also been embolized a few times, he said.
I think particles or something like this. The AVN, the
So
malformation was not changed.
more higher reason for that if they were particles, because what we have seen often is that a big artery, like the vein you're talking about, so you can show it in a it's the one with which you put a blue thing on a blue no
This here.
on that image on that image, yes, yeah.
This
So
here.
that segment there. In fact, I'm not so sure it is a vein because it could well be what is left of an artery after having been embolized, many times. So you occlude the many feeders, the many things that went into that artery, and that's the final segment of many arteries joining together into an artery going to the shunt. And I don't know if I explained myself.
I think it's very clear. We consider this, of course, and we've been thinking of this a long time. The diameter here, which is almost the diameter of the vertebral artery, is a strong argument against it. I mean, I never seen a spinal artery which is as large as a vertebral artery. And if you even consider the diameter here of that posterior spinal, I can go backwards. It is very large, but it's not 5 times as large as this here. So to have a macro shunt with an artery being not as large, but not far away, this is rather 4 than 3 millimeter artery for a spinal artery. I don't think so. And anyway, if you look here again at those pictures, do we see so large macro shunts? This here, I hypothesize that not, indeed.
I think it's residual. You know what I mean? So
no. But he had no NBCA embolization, and he had no occlusion that induced an arterioarterial network. But this is what you mean, that this is an arterioarterial network.
Yeah. Okay.
And the other thing that can help, right, as Dodi and Renee, you're pointing out, is when you have the cone beam CT, when you have the 6D, right? Like we have a chance to see where injecting from every contributor, from every pedicle, where the transition, like where the contrast comes in, like where the mixing is. So if we don't see mixing in this network, that's more probability that that's a venous network.
Absolutely, which you can see here, the amount of contrast in the artery is that white picture. Whenever it arrives in the vein, on the 6D image is always like this, that the amount of contrast is highly diluted. And I mean, could it be the same in arterioarterial network? I would say no. Even if, I mean, we see this, but I don't think so. No, definitely. So here is the attempt of making a plug, which should be here.
So Renee, just to go back for technical point, like the reason you didn't start with coils is because the catheter is too small to place a coil, or you didn't want to?
Yeah, it's a sonic. So the navigability is okay, but not so simple. So here we've got a Magic and Sonic, and even Magic and Sonic, before you may see here that this was tricky. That was not so simple.
I don't know how you got 2 catheters in there.
Yeah, there are 2
is tough
catheters,
enough.
but 2 small catheters are easier to bring in than one larger. So the idea was, in fact, to plug here with the magic, and I fabulously failed because the NBCA was highly concentrated, was supposed to be here. Obviously, I'm a bit too far away, but even if I had a long sonic, you see the tip is here in the vein, so proximal part is there, and I wanted to have this occlude, and you see that it's going in the vein. And this is here, I finally got that plugged, but you see that I lost also a significant amount in the vein, so that was not the goal, and probably this is something that pushed me to do more, even if does not look so good, but the vein is large, and here was outflow, but you don't know what's going on. So this is certainly not what I intended to do, but I mean, you try, and that's life. And here's injection of, I think I took Phil and not onyx or squid, because Phil occludes more rapidly the vein with intention to occlude this. And the difficulty here is, in fact, when to stop, because at some point after you start to occlude the vein, here I shifted to see more what the other part, but here's the tip of the catheter. And you see that other portions are reached, and at some point here, making the control of the left vert, you see that this is still patent, so you continue to inject back, which is being done here. And it took a long time to get that occluded, of course, reducing the blood pressure before you can start to diffuse. But even at that point, you still have things that are open, so you need to continue. And now at least it goes to a portion which is the desired one. This here, if I look by the arteries, was what the artery gives through arterial indirect feeders getting to that vein, which is then being occluded. And once the vein was occluded, here again, this is the last point that was reached, being reached here. And this is here the control. Both anterior and spinal are creeping and very slow. From this T6 left was a posterior spinal getting up, which is connected to T4 right, where we had the access, but it means that it does not have the supply anymore. This is here T4 right. A bit of something is still being there. And this is a 6 weeks follow-up where, I mean, there's a tiny little something. This is now the right one, T4 right, with a posterior spinal that does not make anything anymore. On the left side, if you wait, you see that anterior spinal, which is creeping, but which is getting down. And here's the MR. Patient was uneventful. I expected him because of the thrombosis, as it may induce some more. You see that vein thrombosed. And indeed, I think that's it. For me, here, the striking point was the analysis of the venous angular architecture. And even if you have a macro shunt, I remember the thesis of Emmanuel Houdard on macro shunts, describing that the macro shunt is a connection between up to 3 arteries and a vein. And I think that this is very true. I should have added it here. Very often you see one macro shunt, you don't see the other ones, but at least there were some other connections that needed to be reached, which otherwise could have been an issue.
So, Rene, are there any musculocutaneous pathology of this patient on the liver?
I didn't get it. Can you repeat?
A musculocutaneous disease, or like a Cobb syndrome, or
did he have a Cobb syndrome? No, he did not have. But this belongs to it.
I think that finally I still have my idea. And if you go to the images right during the embolization, so before these, you probably show that there are other, yeah, before, 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 before. There are some other, yeah, probably there before the glue. Yeah,
This
yeah,
is
yeah.
before the glue. This is before the glue.
See whatever. No, I
Here
mean,
are the first pictures.
sorry, sorry. Yes, go on, go on, go on, go on. Because you see other channels similar to the one we are talking about. Forward, 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 forward. Yeah, stop there. Go back one. Okay, you see that there are other larger vessels which are visible coming from the arteries. So you see small arteries and then larger vessels, even above your glue here or your fill, whatever. So not only the one we're talking about, but also above, there is a very similar image of small arteries joining into a larger vessel. Can you see? Can you
So I would
agree?
say that this here and this here, this is the anterior spinal. These are transmedular or circummedular, rather circummedular arteries.
Yeah.
But these here are the I mean, I consider them as veins. And that's why we've decided to fill them. And I would say the argument giving support to this is if these would have been arteries, I would expect that the patient would have some ischemic issue, which he did not have.
And I'm very surprised about that. If I did that, I would have a complete horrible complication. So I'm very happy that your patient went well, but this really surprises me, both on the arterial side and on the venous side, because also by occluding all those veins, you might have horrible, complications like thrombosis, whatever. So very good, and I'm really surprised that nothing bad was happened after all that occlusion. But good, wonderful. I'm
I,
never discuss about yeah. Sorry.
I think that the understanding of the angular architecture on how these lesions are is something that we were not able to. And now we start to have an insight. I'm sorry, these are not the usual pictures we have on this. So this is not the type of image we usually have. It's not thin sliced and it's not as close as possible, but we have here indeed, I would say, I mean, at what point is artery a vein? Honestly, I don't know, but I would say the limit to get occluded is here. And whenever it went beyond that point, we stopped to inject because it was possible to continue, but then we would have gone to arteries. So for us, that was a point to stop. This was a point to stop. And whenever we went into those channels, we considered this here the limit to stop, and we could see it. So we could follow during embolization where it was going, and whenever it was reaching those points there, it was a moment when we decided to stop. Because of course, one thing may happen if you continue there retrogradely, and at some point, if this is occluded, if you continue to push, no doubt that you will arrive to the arterial spinal. So it's scary. That's why, of course, we had the catheter left in the left VA to check this artery all the time and to see how far away we were. But the angel picture did bring something, but not as much as this picture here, where we could make a parallel between the progression of the embolic agent and those pictures here. I mean, the map is this here.
I think I want to make a point and ask a question, Renee. One of the points that I think we should make, and here we're preaching to the choir, but like people that are in general, like to say that we can attack these lesions without the understanding and the mastery of cone beam CT, I think is just, at this point, I think it's just something that shouldn't be done. Like that don't to start to do something like this without cone beam. And you can see how even on an older machine, it doesn't have all the fusion capabilities if you know how to do it, like you can adapt to. But without it, I think it's just like it's like clipping an aneurysm without a microscope and saying, yeah, I can do it. No, this should be standard of care, really.
So, Rene, did you put the patient under heparin afterwards?
Yes, he was under heparin, definitely, which did not prevent his further thrombosis because you don't know how much to give him. That's why we controlled him so rapidly after.
How many hours? How many hours? How many days?
Um, Honestly, I don't know, but we did not. I mean, we gave him a quite important dose. I think the amount of dose is related to your to how much you feel concerned, and of course we're concerned. So I did not want everything to thrombose. That's why I showed also the MR in the end, because even if I did not want it to thrombose, the fact that the shunt was done shows that here you see that this vein here, that's the MR 6 weeks, is thrombosed.
Yeah.
And you don't see it on the angio, so he has other veins that luckily did the job, but which are also there.
So Renee, to this point, you know that in some sense we know that he doesn't need this vein because he's doing fine, clinically, and there's no edema that we can see at this point. So the big vein he doesn't need. The problem would be if other veins thrombosed, as you're saying, that we can't really appreciate that he does need, and we know they have to be there. So we also strongly feel about heparin to give. But this brings me to a question. Like, I guess in my mind, like if we make an analogy with brain AVMs, in brain AVMs, the way I see them is oftentimes you have like a primary shunt, like a high flow shunt, and then there's all sorts of other indirect things, right? And in that situation, like, okay, you close the direct thing, you leave all the indirect things open, it explodes. In the cord, right, we have like some more confidence or less, I would say, like to what you did, like is predicated in my mind on the fact that like they're gonna close all these arteries, but somehow there's not gonna be an explosion. So, which is something that we do in the court, right? Like, can you comment on that?
And another thing which is a bit disturbing is the fact to give heparin or not. If you do an MR on the following day, which we do now systematically, we've been advancing the day when we do MR to do it on the day post, specifically if you want to control the level of thrombosis. The level of thrombosis of the vein is not necessarily linked to the heparin that you give, because when you give heparin, you don't know how much to give. And as you change the mechanical properties and you occlude the shunts, how much of medication you give will really be efficient. We haven't the faintest idea. So we give something completely empirically, and it's only by making controls, and the only way to make control is DSA or MR. So I think MR is enough, shows us how much thrombosis is to be seen next day.
Thank you, Renee. Thank you. Any other questions, comments? How do you choose dilution? Different algorithms, different disease. For Renee, for your question from Blake, like contrast, what sort of contrast are you using? Are you diluting it?
Or for the 6D, no dilution and a lot of contrast, meaning you need to see both arteries and veins. So you need to inject several seconds before to see the whole vascular tree, arteries and veins.
It's very important to have a steady state when you're doing cone beam because if some veins are opacified in some portion of the rotation and not others, it also introduces streak artifacts because of how the algorithm is. But that's now you and us are both using Siemens, various like versions of that. I think whether that applies to other machines, I think we
Yeah.
can ask,
Yeah, that Maxim, you are right. And before make rotations angiography or a cone beam CT, we need to analyze 2D, like a 4 frame per second or up to 6 frame per second if you have a high flow shunt situations. and maximum intensity of the region of interest with filling with the contrast, which second is the most, maximum intention. Those of you information should be applied to the starting point of the cone beam cities and arrival time of the contrast on the region. We have to anticipate before applying the cone beam city. Those of technical aspect is much more important than which machine do you use. Yeah? Of course. Yeah.
Okay.
I still think
Thank
that
you.
Siemens is more adapted for this because as soon as you add volumes, Siemens is just working on the subtracted signal, so that adding subtracted signals is certainly more adapted than adding the whole volume. But we'll see how evolution is going to be. But today, Siemens does this better.
Yeah, I certainly image qualities can be excellent, but not that I will say, take the moment to say that there's a lot that Siemens needs to work on to make a lot of things better. Automatic, like the way fusions are, the automatic fusion can be much better. Just a lot of things can be streamlined, but the basic points are in there. Okay. There are more people that have cases. So if you have a case,
Okay,
speak up,
so
please.
let me share
Yeah,
one
thank you.
case again. So do you see my cursor?
Yes, yes.
Okay, good.
Yes.
Okay, good. So this patient is presented with a very intractable repeated epilepsy and also deteriorated his cognitive functions over the months. And this initial flare is, hyperintensity region of the left hemisphere, including the insular cortex and the whole superior and middle inferior temporal region also. And here is a diffusion weighted imaging showing no significant signal alterations in terms of the no ischemia.
Isn't there something in the right temporal lobe?
No, right
On
temporal
diffusion? Diffusion.
diffusion, yeah, maybe here you see this one, huh? Yeah. This could be also somehow changed, but no symptom related with this one. But the major thing is intractable, very, very severe epilepsy and T2-weighted imaging, also severe signal alterations. And you see that there are lots of pathologically dilated corticomedullary and insular veins and basal vein rosenthal affected in the both sides, but especially on the left hemisphere is more significantly affected. So up to now, what is our major, most probably diagnosis? That is the first question.
Cavernous AV fistula.
Cavernous, okay, good. And other one? Okay, so going, this is again the flare. And here is a time of flight, the original source imagings. The patient is a bit moving, so this is always I started with the contralateral ICA. If the region is a left side, that I always started with the contralateral in order to make it sure that any beyond the midlines and the contribution to the sum of the fistulas point is much more easily to predict and anticipate where is the shunt. But how that it's a bit difficult difference from the actually this patient has no sign of ophthalmologic problem, no cranial nerve palsy and no chemosis and no bruit on the left orbit. Okay. So this is the external carotid. This is the contralateral or more selective induction to the ascending pharyngeal systems. Here is the odontoid arcade. Here is the hypoglossal branch. Some of the jugular branch is reflux to the contralateral, and maybe the lateral and medial clival branch is contributing. beyond the level of the cavernous sinus and a little bit lateral cavernous sinus region. And of course, here is a very dilated superficial middle cellular veins, and whole hemispheric venous hypertension is visible. In the lateral view and the contralateral contribution, also part of the superficial middle cellular veins entering to the sphenoparietal sinuses. And here is the situations. And then going to the left, ICA injection. So-called pseudophlebitic patterns. In the lateral view, you see that somehow that the meningohypophyseal trunk and ophthalmic systems and the ethmoid branch going to the formed some shunt. In the level of the lateral cavernous sinus, it's not so typical location of the CCF. And here is the pseudophlebitic patterns. And external carotid injection of the left side is showing that the high flow fistulas and the directly entering to the sphenoparietal or superficial middle cerebral veins, and no significant filling to the ipsilateral cavernous sinus. The lateral view, this is the situation. So up to now, what is our diagnosis for you? Yes, Luca, please. The microphone is off.
Yes, sorry. Could
Yes,
it
please.
be a diploic arteriovenous fistula? Did you see with the 3D where is the point of fistula?
Very
Is
good, very
in
good point.
the bone or in the
Yeah, exactly. Later, I will share the cone beam CT. Thank you very much, Luca. So this is the ipsilateral selective ascending pharyngeal. If you are presuming that if it is either CCF or the other type of dural AVF, the selective ascending pharyngeal injection is always helpful for us to understanding the local and microangial architecture. And here is a midline, and here is a shunt point. And it's, as Luca mentioned, that it's not typical carotid cavernous fistula. It's more shunt point is anterolateral compartment of the cavernous sinus, which meaning the more close to the anterior crinoid process or lesser sphenoid wing. That is up to here.
Yes, but it could be a type 3 AV, dural AV fistula of the origin of the Sylvian vein from the cavernous sinus. So
Exactly. Yeah. Or lateral cavernous sinus, yes. Then our colleagues, they try to entering through the transvenous approach. Initially,
sorry,
yes, please.
masters. Seems to be that meningeal feeders are few respect all the others. Not so the if you
No.
see the left meningeal artery,
Yeah,
it
this
seems
one.
to be normal, quite normal. So I don't know exactly. I would see in the 3D on the vaso CT what is the point of fistula. If you see in the bone, I think it's
Yeah.
not exactly a dural fistula, AV fistula.
Okay. Thank you. So, but before going to the cone beam CT, that this is a transvenous approach that the colleague tried, and the venography was performed, but completely independent from the AV fistula point. So shunt point is not on the line, not in the cavernous sinus, even not on the lateral cavernous sinus. It's a bit another situation. But this is a selective injection of APB middle meningeal artery. You see that the recurrent meningeal artery entering on the level of the anterior crinoid process and form the AV shunt around here. So this is an initial angiographic observations. Here is the recurrent meningeal branch and entering to the orbit, and here is a shunt point somehow, but still a bit difficult to identify where is exactly shunt point. Therefore, we need this is selective angiography from the recurrent meningeal artery. we're going to the, here is a cone beam CT. So this is external carotid systems, and here is the orbit. You see that the all meningeal and intraosseous arterial supply is convergence in the level of the lesser sphenoid wing, and suddenly forms the AV shunt, and the initial foot vein is a kind of bridging vein connecting between the interosseous bony structure and deep sylvian vein or sphenoparietal sinus, if you can say. And here is a coronal view.
Michihiro, can you show us this vein on the cone beam CT, where it is? I did not get it. Where is the origin of that vein?
If I can stop here. Here, maybe all this arterial supply entering to one point is here, which is inside of the very near close to the anterior crinoid process is here. This is the contralateral anterior crinoid process. This is the ipsilateral anterior crinoid process. And here is the initial foot vein. Later, I think that the more another aspect that we can.
Yes.
I mean, on this particular image, though, I can also say that that's like sort of like a common arterial collector, and I can point to the shunt a little more posteriorly. That's another option.
I see.
Right.
Okay.
Meaning that we're very close there, where we think is where it's very close by. It's just like the compartment, in if I say like, okay, this is like in the anterior cavernous sinus, somehow disconnected from the posterior cavernous sinus. That's why you don't see it from the IPS. That's just another idea based on these images.
And therefore difficult to exclude the hypothesis from Dodi.
Yeah, excellent. Yes. So already we have.
I mean,
also...
we always have this discussion if this is an artery or vein. But practically, like for everybody, like what is the practical implication of all this discussion? Is the question is where do we start? Like where do we put the embolic material into the cavernous sinus and how much? Right? Because otherwise we are not going to have access to it as well as we may have now. So there are practical implications to all of these discussions.
Excellent. So you see here, maybe terminal feeding artery, meningeal artery, or interosseous branch entering to the level of the lesser sphenoid wing and entering to some venous compartment. And this venous compartment forms initial foot veins here and entering to the superficial cerebral veins here. So this is another, it's more easy idea for you. A selective injection from the recurrent meningeal artery. And you see that the arterial meningeal supply, and here is a one convergence. Here is also, you can appreciate that the selective recurrent meningeal arterial injection, and here is a convergence in the level of the lesser sphenoid wing. Here, this one, and it is the same. So another injections. This is the same, and here marathon type of microcatheter and the selective injection is exactly the terminal feeding arterial systems, and suddenly the caliber change is here, and this is still interosseous, and here in the initial foot veins connecting to the superficial middle cerebral vein. So then we did just a transarterial embolization from the onyx one by ones, and here is immediately after. Still pseudo-phlebitic pattern is remaining, especially in the insular cortex. The insular level of the cortex was suffering with a venous hypertension, which was the cause of intractable epilepsy. But afterward, we also put the patient under 24 hours up to 48 hours heparin. And here is immediately after the onyx injections and the coronal view. Here is a sagittal view. You see that already the drop of the onyx makes some artifact, but here is the initial foot veins connecting to the superficial middle cellular system, but here is the terminal feeder was fully packed with onyx. And here is another view. You see, this is what we did, while, of course, pay attention to the connection to the ophthalmic artery. But in this case, the ophthalmic artery is predominantly supplying from the ICA. So we carefully look at just in the entrance of the orbit, in the apex. And here is the most difficult point that we have to pay attention, but certainly the onyx didn't enter into the ophthalmic systems. And here is before and after embolizations. And the most important thing is that this is the before embolization. That's just 3 weeks after embolization. You see that all the resolutions of these venous hypertensions. That's it. Thank you.
Thank you. Beautiful.
So
But
any
I
question?
didn't, I didn't get what finally you thought this was a dural or bone dural fistula.
Yeah, this was a dural fistula, but shunt point is a lesser sphenoid wing.
So in the bone,
In the bone, yes.
not on the dura.
Not on the dura, but initial foot vein is inside of the bony structure. But shunt point is actually terminal feeder, or the terminal feeder is a meningeal arterial system.
Yeah, or bone arterial system, because they're probably
like an anterior condylar conference or cavernous CCF on the posterior crinoid process is also somehow initial foot vein is locating inside of the bony structure of frequently we observed.
I mean, we have these discussions, right? Part of the issue is that, of course, dural vessels supply bone, right? Like middle meningeal artery and the like what supplies bone is what lies on both sides of the bone to variable extent. So sometimes like more, sometimes less. So I think that's part of what makes it difficult to decide is because meningeal vessels will supply these things.
Yeah, but also you have to, in some way, think that the venous system, so the middle cerebral vein system, superficial, before the fistula, it would drain in the bone because that's where the vein is going to or coming from, which it makes little sense to me. I mean, I think that system, the one which was draining the fistula, normally it would drain in the cavernous sinus. Don't you believe that? Yeah.
Yes. Or lateral cavernous sinus, or independently from the cavernous sinus, but directly draining to the pterygoid venous plexus.
Exactly. So both of them would be not in the bone. So why there should be a fistula which drains into a vein which would drain into a system which does not drain in the bone? To me, it's much more simple to explain it with a normal dural AV fistula type 3, like, on the surface of the transverse sinus, where you have, of course, if you inject from the sinus, you don't see anything. But in that case, you would have the arteries going into that vein, coming, and arteries which also would go through the bone. And so you would see arteries in the bone, but draining finally into a vein which is only in the dura. I don't know if I explained myself.
Yes, I think, Dodi, you are right. if the superficial cerebral veins directly entering to the cavernous sinus, is of course it's a normal situation.
Yeah.
And the so-called sinus of Breschet, yeah, the sinus of Breschet
Yeah.
is a sphenoparietal sinus.
Yeah.
It's a microsurgically is directly entering to the cavernous sinus, but sometimes it entering to the bony structure through the bony structure, draining to the extracranial system. So it can happen that in the both two drainage patterns. I mean, I don't mention about the
Okay.
AV shunt, just the normal venous drainage system. Yeah. Mm.
Okay. Okay. Thank you.
Michio, I think it's a very nice situation, a very nice explanation, and that's fistula. I think that considering a venous approach is also a healthy thinking, so I would rather support this. But if I see from the beginning that there is no connection to the cavernous sinus, um, probably these are not the veins I would consider, but rather the veins of the outflow of the fistula, and there was some indirect veno-venous network somehow getting to the suprasagittal sinus. I think that your choice and your strategy was a good one, but it does not completely exclude the vein, but vein probably more difficult here.
Yeah, yeah. Of course, that our colleagues wanted to transvenous approach, which is more secure, easier to understand. But any attempt through the transvenous approach, I mean, that's IPS or peripheral science, but failed because there are the compartmentalization. It's not the thrombosis; it's some compartmentalizations and like a trabecule of the connective tissue. So shunt point is independent from the cavernous sinus at this particular case. Yes.
Yes, we did not see the fistula draining through the cavernous sinus. Point one and point two, even if you see it navigating through the cavernous sinus through veins is possible, but probably belongs to the most challenging venous accesses.
Yes. Thank you.
Let me just quickly show something, a normal venous drainage.
Yes. Yes.
Let's see. Here, I don't know if it's exactly the same sort of situation, but I think it's on the spectrum, if you will, of what happens. You have like these sylvian veins, and then like sort of like a lot of kind of a mess here, but you can see that these are not normal, typical pattern, that these are probably diploic veins or somewhere like this. And this is the cone beam of this here. You could see that at least in part, you see what's opacified here is the same area, the exact
Yeah.
same area
Yeah.
that you showed in your case, like this, right? So
Yes.
I think that's in some cases, if there's a variation of normal drainage, that becomes the connection. And that may explain why, you know, if the sylvian veins were draining into the cavernous sinus, right, there would be like, probably the person wouldn't be suffering so much. It's just like if it's exactly draining into the bone here, that's when the fistula directly has access to the veins, and then you have this big mess in the temporal lobe that you had. So maybe something like this
Yeah.
to begin with.
And yes, as Maxi mentioned, that any of our prior normal venous systems can use, of course, bridging vein normally, of course, entering to the interdiploic space and draining exclusively using the interdiploic venous system. So that is it's not so often we see, but there are lots of cases which is a normal drainage system is using the interdural, intrabonish, or so-called interdiploic venous system. Yeah.
And that gets back to cone beam CT, right? Like, unless we do this, we really don't understand all these other drainage pathways that become important. Some more for cone beam. Okay, Chihiro, thank you so much. I know we're running late because I think there's more people that want to showcase it, so we can stay, keep going if everyone is willing. I know Luca had a case, right? And then Maybe, Luca, you could share your screen.
I'm trying. Can you see it?
Yeah. Double click to enter full screen mode. Do you have like two screen? Okay, yeah, we got you now.
Okay. Good evening to everybody. Thanks to allow to present this case. It's a story of a man, 73 years old, with progressive paraparesis, and we did the MR, and you could see myelopathy and some vessels. Maybe the vessels are not so clear, but trust in me, there were some. And we decided to go for angio. I show you just the Adankiewicz. There was no AV pial fistula. And at the end of the procedure, we analyzed all the thoracic and the lumbar segment. We ends with the iliac artery. The patient was stay awake and a lot of gas in the bowel. So on the right iliac internal branch, we saw this vessel. Maybe you could see, very difficult to see. And we decided to repeat the angio in the general anesthesia the day after, and we saw this. Very slowly AV something in the sacral, and we go more deeply in the left iliac internal artery. And again, maybe there is a shunt in AP and a kind of lateral projection on the right side, but we didn't see any veins. So we decided to go with the microcath. This is an Edway Duo, 177, and was the injection. And finally, we could see an artery, probably veins, and maybe another vein that we interpreted like a pial vein, a radicular vein, sorry. And we go more deeper. We went more deeper, quite in the quite proximal to the shunt, and this was the injection. We couldn't go farther than this. And finally, we could see the vein, a radicular vein. Obviously, the vein went up in the medulla. We did a basal CT. And I don't know if you agree, but we thought it was an epidural arteriovenous fistula at the level of the sacrum, draining in the left S1 vein with the usual loop around the S1 root. Do you agree? Yes or no?
Agree.
Yes, for my part.
Agree.
Okay. So this was the metameric branch, dorsal branch, the fistula, the pouch, the Baxton plexus, and foraminal vein, bridging vein, transdural. We interpreted it like this, and this was the perimedullary vein. But we noticed even these.
Radicular vein, not perimedullary.
Sorry, radicular
Radicular, yes.
vein. Sorry, Rene, you agree? And we interpreted this blue and the other violet like other foraminal vein and another radicular vein, sorry, not perimedullary. What to do? Anyone leave the piece of bread to the surgery, or we go for an injection of FEMA, and this was the cast. And I was a little bit at the end of the procedure surprised because we saw that this was the last runs. Everything went in a good way, and we thought that was healed. But the point for me is that before the catheterization, with difficulty, we could see the vein, the radicular vein. When it was just above the fistula, we could see other radicular vein, other things. And when we inject FEMA, we see more and more. And this was the cast of FEMA. This was a MIP of the cast. So I don't know if I just in a psychiatric session. So, but we classify more intradural veins than we expected in the microcatheterization. With Phil, we saw more veins, more intradural veins that we expected. These ones. And the thought was that we saw more veins than we expected because we created an occluded system. So the micro was in a wedge position and all the foraminal veins were occluded. Do you agree with this or not? If we're not an occluded system, probably my injection could, the contrast could go outside the vertebral channel, outside in the paraspinal veins. You agree? Not agreed?
I agree. Yeah, I agree that there are,
So,
because each has a connection, right and left also intercompartmental connection there. Yeah.
so when I injected from the microcatheter, the vessel opacification was dependent on the resistance that we met when I inject. But when I inject the FEMA, the solidification has no limits. Follow a pressure gradient pathway. When you obliterate all the stuff, it could stop. But if has no pressure, it occlude before the low pressure zone, then goes in other ways. So it should be in my head that should be exist really an anti-reflux system in the dual sheets of the spine. And I don't know if it's a stupid idea, but probably are the bridging veins or the transdural tract of the veins. So the stenosis that we saw when all the fistula, epidural, dural, AVM, in all the way, when we saw the veins from the pile perimedullary space exit from the dura, there is a tract of the veins that is stenotic. I don't know if I say something wrong. And the Philippe Gaillot wrote this article that it was very interesting and analyzed all this stuff and say the probably this part of the radicular vein where there is a stenosis is the point that doesn't allow to the blood to come back in the intradural space. So it's just not a sophisticated system, but just a stenosis of the vein inside the dura. That if you have that, it's an anti-reflex system, and the stenosis prevents the reflux, probably with the angle of the exit of the radicular vein. And I obviously remember my case of a couple of years ago when we inject in another fistula in another patient from the artery, and we saw a scenario like this. But when we were in the veins injecting by L1, L5, S1 foraminal vein, we inject retrogradely, we saw more and more things, even the artery, because it was in an occluded system. Probably this injection wins the anti-reflux system of the veins. And the answer is, I'm sorry, I haven't the pointer here. Yes, blah, 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 blah. Freccia, yes. Visibile. Can you see my,
Yeah, we can see it the whole time. We can see it.
okay? Here, and here, in all the stuff, there are stenosis that probably physiologically doesn't allow to the blood to come back in the intradural space and can answer to the they are even in the intrathecal inside the vertebral channel, see outside the passage between intradural inside the channel and outside the channel, the paraspine in the paraspinal space. So I don't want if I did an obvious thing or a stupid things, but was for me it's an answer of the question when we have, for example, a huge flow epidural fistula that doesn't have an intradural drainage. Why? And in this case, when we have a slow flow fistula, very slowly, we don't have any intradural drainage. Probably because the stenosis, the variational caliber of the radicular vein doesn't allow to have the reflux inside. I don't know. This was my point, and I finished. Thank you.
Thank you.
You are saying that you created AV fistula, I mean, no, intradural reflux where there was none. So you can create a problem when there is no problem.
Yes.
Okay. So you created a problem and you occluded it at the same time. Very good, Luca.
No, but is that what Lucas, is that what you're saying? Because there was a shunt, like an MR, the patient was symptomatic, right? You were
Yes,
searching
yes,
for
yes, yes, yes.
you were searching
Yes.
for a shunt and you found the shunt. So
Yes.
part of the message of this case is again like attention to detail. Like, right? Like if to understand spinal anatomy and look for the shunt. At first it looked like, oh, I don't know, maybe, maybe not, right? And then the more you look, the more you see.
Yeah, but he finally found that shunt, but he also found
Other
shunts
shunts.
which were not there before.
I'm not so sure.
Well,
I don't know. I have a different, like, I think, I think so. When we talk about connections, and this is probably too long a discussion, right? But like to me,
yeah.
I try to think like I think if we think of pressure, like just what makes flow is pressure difference. From higher pressure to lower pressure, stuff flows, right? That's the fundamental principle. And so, like when we think of wedge position, that basically has to do with pressurizing the wherever you are from the wedge from the like flow control position. The more distal you are, the more you can fill the epidural pouch that you are in. And so the pressure in the pouch rises. And so that creates like allows you to see other connections because you have higher pressure inside the compartment that you're injecting into. And conversely, there are others, maybe other arterial supply to that area, right? That you're not pacifying from a more proximal position. But because the pressure inside the compartment you're looking at is lower, I don't know if that is another way of looking at it.
But I don't think that this is necessarily in opposition. I think that
No.
there is, I agree with both of you. I think that nature is super well done, and there is always an anti-reflux mechanism that Luca describes here very well, and that Philippe Gaillou wrote, and that you see also in the brain. To access a cortical vein, you have always a U-turn in the lateral view and a 90-degree curve or more in the AP view. A double angulation, same thing at this double angulation, which prevents any increase in abdominal pressure to have the spinal veins receiving this increased pressure. So here with the fistula, the pressure is too high and then it leaks inside the radicular vein. That's why you could cure it. The only thing which I find at some point difficult to analyze is when you continue to inject, the large structures are veins, the small ones, are they small veins or arteries? It's not so easy to say.
Yeah, I think so too.
I think so. They were veins, but obviously I'm not sure about it. In the vasocity in the CT scan after the treatment, they seems to be all veins. If you want to see again,
May I share just the picture? How can I
There
share?
is Fabian who wants to say
Fabian.
something, maybe.
Fabian, please. Yes.
Hello guys, thank you for a super interesting seminar so far. Many of you have touched upon the transition of epidural veins to spinal veins to intradural, right? Dodi, you showed the case with epidural fistula draining into the intradural veins, and this was another nice display of a potential anti-reflux mechanism of this transition, this connection. But one thing, these are all very rare cases. So rare pathologies, we see them from time to time. But now we're transitioning into a very high volume scenario, the CSF venous fistula, right? Where we feel we put a lot of liquid embolic material in the epidural and the paraspinal veins, right? A lot, and we push, and somehow I have not known or seen or experienced the transition of liquid embolics from the paraspinal epidural veins to the spinal veins by doing this. So how is this possible? I mean, should we be, when we increase the volumes of this procedure, should we be aware or afraid or cautious about pushing liquid embolics into the spinal veins by this route? What do you think?
Fabian, I know Walid has one case, so he shows one case of that happening, right? I don't know if you've seen it.
I've seen it.
You've seen it, but that's the only one that so far we haven't had any. So
Yeah.
the normal,
So-
whatever the anti-reflux mechanism is, seems to be working quite nicely. Except in these fistulas, right? Like it must fail by definition in an epidural fistula. Otherwise, there wouldn't be one.
Yeah, so
connection.
and now extensively navigating, exploring the venous anatomy, the paraspinal epidural, it's a huge system. You can see Michiru's image here. How it's also a thing of pathology. How is it possible for epidural fistula to drain spinally? There must be a disease of thrombosis creating compartments and so on. But super interesting seminar, guys. Thank you.
Yeah, actually, Luca clearly demonstrated this, lateral epidural veins and the medial epidural veins, and of course, at the ascending and the descending lumbar veins connecting, and also the level of the lamina foramina also. And as he explained that this is the cadaver injections, so this is exactly epidural venous plexus entering to one of the radiculomeningeal veins. And here is, of course, this is a cadaver dissection from the Professor Tron. And this is our high resolution cone beam CT after glue injections, also showing that this kind of, you see that the sort of valve systems.
Sorry, Michihiro, we cannot see that. Do you see it, or is it me?
No, we just see contrast injection.
Okay.
There's two pictures, cervical level and upper thoracic level, epidural venous plexus.
Oops. Okay, I will check again here. Do you see this?
Yeah, this is good.
Okay, so I continue to hear. This is exactly the cadaver dissections that the textbook from the Professor Tron. And here is our cone-beam CT after glue injection that's showing that the same configuration where the radiculomeningeal vein is entering through the level of the nerve sleep. And of course, the spinal dural wave is not necessarily always using the nerve sleeps. It's sometimes independently from the nerve sleeps, and one breaching veins is exactly entering to the spinal venous system. But here, certainly, Lucas clearly showed the venous structure. So more you push, more you visualize. That is a venous plexus system on the paravertebral system. Thank you.
Okay. Thank you. Any other questions? Okay, there was a question from Rupa. What is FEMA? We don't have FEMA either.
Feel
Feel.
is
Okay, so same as
is
feel.
like Evo
Is or
for
different?
Onyx. I prefer to call it with chemical acronyms.
You mean Onyx, right?
Yes, the same of Onyx, but
Okay.
Okay. All right. Thank you. I think, okay, next, let's see. We have Dr. Yang. If Dr. Yang is here, to please show your case.
Okay.
Thank you.
Sorry. Sorry.
That's okay. Take your time. Uh-huh.
See my
Yes.
screen?
Yes.
Okay.
Yes. Now let's see if you can, yeah. Uh-huh, it's good. No?
Okay.
Okay.
It's my pleasure to presentation my case on Plan Online. And this is a cortical venous approach for direct ablation of cavernous sinus arteriovenous fistula. And this patient is 71-year-old female and presented right active thalamus and pastile tenderness for 2 months. And physical dimension shows the right oculomotor paralysis. And this is the eye examination. We can see the right oculomotor paralysis and oculomotility disorder. And GMI shows the abdominal fluid in bilateral cavernous sinus. And this is angiography. Right EC angiography shows the cavernous sinus DIVF. And we can find the fistula supplied by the right ascending pharyngeal artery and medullary arteries. Sorry, and drain to the right cavernous sinus and reflect to the right superior middle cerebral vein. And this is a left side EC angiography, also supplied by the left EC and drain to the left cavernous sinus and reflect to the left ophthalmic vein and to the right superficial middle cerebral vein. And this is IC angiography. And the right IC angiography, we can show no bleeding supply to the fistula. And the left IC angiography, we can find the manager branch of the IC supply to the fistula. But we find bilateral inferior petrosinus was no visualized. And this is the vertebral artery angiography, and the right vertebral artery occluded. And the left side vertebral artery angiography show no blood supply to the fistula. So the pre-operation diagnosis is cavernous sinus DAVF and supplied by the bilateral ECA and the left ICA, and drain to the cavernous sinus, and then reflect retrograde into the right superficial middle cerebral vein and the left ophthalmic vein. And as we know, for the treatment of the cavernous sinus include transartery embolization and the transvenous embolization. And for transartery embolization, we perform the embolization via the branch of the ECA or the managerial branch of the ICA. And for the transvenous embolization, and the embolization were performed via the inferior petrosinus and or the fissure vein to reach the cavernous sinus. But when the neither for case neither TAE or TAVE were feasible, we will choose to combine the embolization with direct puncture of the super ophthalmic artery or cortic vein, or direct conventional sinus puncture. And in this case, we can find the feed artery arises from the bilateral extending pharyngeal artery and maximal artery, which were both small and torsos, with no suitable access routine available. And for the transvenous embolization required a patent and accessible branch of the cavernous sinus, typically the petrosinus or superior ophthalmic vein. But in this case, we can find no optical trans. So we choose open craniotomy with direct transvenous embolization for cavernous sinus DAVF with the superficial mid-cerebral vein in hybrid operation room, alongside transfemoral angiography for continuous monitoring. And first, we performed frontal and temporal corollary and exposed the severe drainage, severe vein, and then performed the ICG angiography and confirmed the severe draining vein, and then exposed the severe vein and temporarily clip the proximal and distal of the vein and direct puncture the vein, and then perform the angiography through the puncture vein and confirmed this is the cortic draining vein, and then microcatheter was advanced to the left cavernous sinus, and consequent angiography confirmed the microcatheter was positioned in the left cavernous sinus. And then we inject the Onyx 18 to embolize the left cavernous sinus and the inter cavernous sinus and the medial wall of the right cavernous sinus. And this is the cast of the Onyx. And we perform the left CC angiography and find still the fistula residue. And then we continue to inject the Onyx 18 and to embolize the right cavernous sinus and the intercavernous sinus. And finally, perform the left CC and the EC angiography and find the fistula will totally include. However, we find Onyx glue migrate from the manager branch of the left ICA and to the M1 segment of the left MCA. And then we to mechanic remove the Onyx cast. And during the operation, we find the Onyx cast shift to the M3 segment. And we find the patent was patent and don't influence the blood flow. So we didn't to attempt to retrieve the Onyx cast in the M3. And 10 minutes later, we performed the left IC angiography again and find the Onyx cast was stable and the M1 segment of the branch of the left MC was patent. And finally, we also performed the right IC, right EC, and the left CC angiography and confirmed the fistula was totally embolized. And then we secured of the saving draining. And this is the post-operative CT scanning and show no bleeding. And you can see the Onyx cast which in the MCA segment, MCA, and the position was clear to the cortic branch. And this is the post-operative MRI and show no acute infarction. So finding the patient total operation view with no new deficits, and the right hypothalamus and occipital paralysis had improved. And we include combined craniotomy and the puncture of an intracranial draining vein in hybrid operation is a valuable alternative strategy for treating completed cavernous DAVF when neither TAE nor TV is feasible. But it's to note that the blue protection of the IC is indicated to prevent the escape of the embolic material and the potential occlusion of the intracranial arteries. That's all my presentation. Thank you for your attention.
Thank you, Heng. Thank you. A lot we can discuss here. Thanks for the case. I guess one thing to start is to go back to your diagnostic images.
Okay.
And I think it's very important to understand exactly where the shunt point is. Because you say that it's a cavernous sinus fistula, and I will be a little bit strong here, Heng, and I will say that that's not good enough. Like there are left and right cavernous sinuses, and it's a big structure. So the vast majority of cavernous fistulas in the cavernous sinus are located in the posterior lateral aspect, right?
Yeah.
And so let's look at the images now, and let's see if we can understand a little bit better where the target is. I think here the frontal images are more useful because to differentiate left from right. So here we're injecting. Okay, so let's stop. Let's stop here. Yeah. Let's go back to the right-sided external injection. Okay, let's stop. Okay, here. Now, on this image, where do we think the shunt is? On the left or on the right side?
I think it's located in the left side.
Okay. I mean, based on this image, I'm not so sure. But maybe if you have like an concept, like if you don't have a bone view, like is this the left, like are these arteries are pacifying the left cavernous sinus or the right one? Here it seems to be more like the right. I don't know if anybody else has a comment on that.
I would like to see more about the ascending pharyngeal selective injection on right side, because right now this external carotid injection is already the tip of a guiding catheter, diagnostic catheter beyond the orifice of the ascending pharyngeal system. So we're missing something, the angioarchitecture, right?
Yeah.
Because in most of the CCF, ascending pharyngeal selective injection is more helpful to understand the angioarchitecture, where is the shunt localization. And on this picture looks like the intercavernous channel on the posterior aspect, close to the posterior clinoid process. But still right and left is, I'm not sure. I cannot say from this angio.
Okay, so let's see what else we have.
Maybe we perform the composite and to
You have
yeah,
I think the cone beam helps definitely, but you also have, I think you have other injections, right? You had a injection of the pharyngo of the like a pharyngo-occipital trunk, like occipital artery and descending pharyngeal later.
Yeah.
Let's see what else you have. Okay, now okay, let's go more. So here we see mostly it's the right-sided Sylvian veins that are congested, but also the left ophthalmic vein. Okay, Wei, I think Wei, you want to say something?
Yeah. I'm sorry, I cannot open the camera because I'm in the taxi. It's quite dark here. And let me explain for this case. Explain some things. But I think this is case. As I remember, this is a actually this is a I think this is a bilateral fistula, bilateral cavernous fistula. I think the right from the right ECA, you can see the ascending pharyngeal artery was participate in the blood supply. You can see after the injection of the right ECA, you can clearly see the cavernous sinus. Yes, there is a very early drainage of the cavernous sinus. But for the left eye, for the left injection, I think there is a similar location of the fistula in the left side. Uh, could you show the image? Hen, could you show us the image again? for the left side.
Left side.
So actually, our treating purpose at that time is that we try to occlude the bilateral fistula. So thus we use the right sylvian fissure to puncture the right sylvian fissure, and then navigate the microcatheter to the left side at first. So our intention at that time is to treat the left, occlude the left side cameral sinus, and then retrieve the microcatheter to the right side. So actually, at that time, our diagnosis is a bilateral fistula. So well, I don't know whether this is a good, correct diagnosis. So this is what we want to discuss today.
Based on the images that we have, and I do think cone beam probably would solve the issue, but based on the images and the final glue cast, right? When you see the final cast, in the final cast, we don't see fistulization once the cast reaches the intercavernous channel, right? The majority of the cast is on the left.
Yeah.
There is a little
Almost
in
the
the
left cavern
almost in
sinus.
the left where we can see the some glue or some onyx was in the intercavernous sinus.
Yes. So once, and that's when the fistula, that's when we stopped seeing the fistulization. Until that point, as Heng showed, there was still a shunt. And then once that structure was filled, that's when the shunt, I think that's when the shunt stopped. Correct?
Yeah.
Yeah.
But actually,
Which,
finally, there is some residue in the right side, I think.
Finally.
On the right ECA.
No residue.
Oh, no residue.
I mean, angiographically, it looks like a good result right now. It certainly would control him with an angiogram in whatever time, 6 months or something like this, and make sure that it stays closed.
Yeah.
But the intercavernous sinus, right, is that if that's the location of the fistula, that would probably make sense, right? Any other comments?
So intercavernous sinus of right side or left side or midline? That's my question.
I mean, somewhere back there. I think this is, again, like to the extent that I think cone beam, if the capability of cone beam can be very helpful.
Yeah.
I would make some comment. I mean, thank you for showing a really a tough fistula with a nice job, very nice things done. Just from a principle, most angiogram diagnostic are done on a 32 or 42 centimeter field of view. And all the questions we're just raising now are quite difficult to answer. I think that once an overview is done, it's worth to make, again, angios with a 16 or 20 centimeter field of view to see better. I presume that potentially this is also the reason why, I mean, a complication occurred that luckily had no consequences, but working with a big field, a small field of view is certainly a very, very important help. In the treatment option, you spoke about transarterial embolization. Let me disagree with this. I mean, of course, from a general point of view for dural fistula, yes, but we certainly agree that for cavernous sinus fistulae, it never clears the fistula and always induces complications. So I think it's important that we state here that transarterial embolization is in fact to be excluded for cavernous sinus fistulae. There is a way. Then the puncture of the vein, I mean, congratulations. That's really nice that you did it. It's not easy because when the vein arrives at cavernous sinus, there's always a U-turn. is not straight. And if you have no guiding, it's not easy to hold it because the catheter is always kicked back. So you manage to do it. I think it's really tough. I think that here making a direct stick, direct puncture of the cavernous sinus is certainly much more simple because I mean it's tricky to puncture. You don't want to puncture the optic nerve, but you can do a couple of cone beam CTs and you avoid the craniotomy. You're directly inside, and once you're in the sinus, you are already inside. You don't need to catheterize the junction between vein and sinus. So nice to see that it works, but I think that in those patients, it's certainly not to be forgotten that a direct puncture of the sinus is today a very good option too, regardless of the recanalization of the inferior petrous sinus that we've been doing for years. That usually works, but I think that the direct stick is a better option.
Yes. And
Yeah.
in my view, transarterial embolization for CCF and causing the MCA migrations, MCA infarction is well documented. But your case is transvenous onyx injections, and as a consequence, you had the very small migration of onyx can be seen on the MCA. This was a bit for me is of course potentially it can happen, but which route was entering to the ICA? That is my question. Did you see any inferolateral trunk from the transvenous injection of not onyx but with a contrast? Did you see?
Let me explain. Yes, we have seen a very small trunk from the ICA, which is connected with the fistula. Cavernous sinus, you can see from the angiogram of the left ICA. But actually, for this case, I think a complication occurred due to our this procedure. For this procedure, after we place the microcatheter to the cavernous sinus, we will do some very loose but very loose, but we will tight we want to stabilize the microcatheter, so we will use the string or thread to temporarily occlude the distal superficial silvery vein. So that's mimic the situation of the pressure cooker technique. So that caused the onyx. Maybe this is the main reason that onyx because we create these kind of situation that the hypercooker technique. So the onyx maybe reflects to the ICA through this very small tunnel. That the connection between the between the cavernous sinus to the ICA to the MC, then the onyx shift to the MCA. But if in the regular transvenous approach, there was very seldom this will happen.
Yeah.
Because yes, you will not temporarily occlude the or you use the balloon to do the pressure cooker technique intentionally. But for this kind of cases, this is a hypercooker technique because we use the thread to stabilize this. So maybe we will tight the superficial silvery vein and cause this situation.
So you use the hybrid OR, huh?
Yeah, hybrid OR.
Good job, thank you.
Yeah, definitely one of the approaches. I mean, I think I agree. Like generally, I would second what was said. I think it's important to look at the inferior petrosal sinus as a root. And like just on a CAT scan, we can see if there's a groove there or not. It's not always that we can go through it, but we probably half the time we can, if we don't see it. So that's one way to go. The direct transorbital, we've done like a good number of times. It's a really good approach. It looks like dramatic, but it's usually highly effective. It's important, if you go on neuroangio, there's a couple of cases of that. So I invite you to go and see them and their publications and that. So I think that's an important thing to have in the armamentarium of like what our possibility. Not every case is good for that, but I think that's another thing we could use. Some of the questions that came up in the chat, where people are asking about coils, like how come instead of using a liquid embolic, why didn't you want to coil it, which reduces the risk of embolization, of course, into the MCA. So can you touch on that?
Yes, using coil is a good option, but that means because we cannot, it's not very easy to just use the coils to embolize this tibial sinus fistula, right? So maybe for this situation, maybe sometimes you need two catheters or use one catheter and then inject glue. This is also an option, but for these very small tunnel, we make a very small incision. If we make a bigger incision, it will cause bleeding, because there was the incision and there was the high flow blood just coming out of because this is a fistula. You can see we can feel that there is a lot of blood just coming out of the small incision, and we don't want to cut too much. So just one small tunnel to let a marathon like this kind of very small microcatheter to be inserted to this very small incision.
Yes. Yeah, for sure. For
Yeah.
sure it can be difficult. And as you said, like we also prefer to have two catheters when we're dealing with these. Always better. Vittorio raised the hand.
Hi, everybody. Beautiful case. I have a question because on the direct puncture approach, because if you've done several cases, I've seen this beautiful presentation at the Alice and in London some weeks ago. I have a question because in our practice, we would have tried to pass through the inferior petrosal sinus in a classical way, but why this? Because we want to put as less material as possible inside the sinus, because we as coils or onyx, because we are afraid for the cranial nerves. And so we want to close the exit way as the first thing to go. No, so if you have the middle cerebral vein, you have to close this, or the superior ophthalmic, we want to close the superior ophthalmic. That allows us to put less material inside the carotid sinus, because the occlusion is faster afterwards. And then you are safer because you have closed the most dangerous exit way. So the question I want to ask, if you do a direct puncture, how can you direct, to the exit way? Can you target the exit way, or you just go inside and you just inject random inside in my head? So I really don't understand. Is it that, or do you have a technique to target the exit way? So the first thing you want to close in this kind of fistulas. So that's a question, technical question. I don't know if for you, Maxime or René or whatever, whoever does this technique. It's very interesting. I mean, it's a fantastic technique. I would like to do it, but I want to understand this.
Yeah, go ahead, Wei. No, you guys answer.
This is a very difficult question, I think. For these why we choose the direct puncture between the sinus is always a good option. But to be honest, we are not quite familiar with just the direct puncture of the orbital area, because I'm not quite familiar with this kind of procedure. And for us, the simplest way is to create the access by the visible vessels. So this for me is the simplest. So for this case, the simplest way is to puncture the Sylvan fissure for me, because it is visible on the DSA, and we can do any. We have multiple methods to achieve these kind of access. But the before the operation, we definitely we will evaluate the outflow or the inflow of the fistula. But for this case, I think the most dangerous outflow is just the superficial, the Sylvan fissure, because this is the a retrograde flow, and this is a reflux to the cortical vein. So this is the most important, most dangerous outflow. So we choose this way, and finally uh, we can make sure that the most dangerous outflow was controlled by our by this kind of access, because we just put the microcatheter in the superficial in the Sylvan fissure, and we definitely will occlude the superficial vein, right? So this most dangerous tunnel, because we put the microcatheter in this outflow.
Yeah, no, for sure you're controlling by that you're
Yeah.
controlling that thing. I can Victoria's question is more like navigation inside the sinus. Once you're in the sinus with your microcatheter, how is the navigation to wherever you want to go? I mean, in my experience from like direct punctures, it's similar. Like once you're inside, we navigate with like just
It's
go
not
to where,
very.
wherever you need it.
You,
Um,
we have two operators. You should cooperate very smoothly. One should hold the microcatheter. The other one is using the microwire to super select the vessel you want, the location you want. So once you advance the microwire, the other guy should cooperate very well, and then advance the insert the microcatheter through this microwire. And yes, this one have a very heavy radiation, because he is working just under uh, the tube, under the plane. So everyone, both guys should cooperate very well. But I think uh, it's not very difficult if you cooperate very well.
okay. Dodi,
Now,
thank you.
yeah, I just wanted to make a very brief historical note. 42 years ago, so that was before coils and before liquid embolics. We had a case of a direct carotid cavernous fistula, which was not available, accessible from the neck, from the carotid. And so with the surgeon, we decided to open the head and puncture directly the cavernous sinus. And through that puncture, it was deployed a balloon, a detachable balloon, which was inflated in the cavernous sinus because there was no other way to get there. So no, it just reminded me of that case, and I admit that I don't remember what the outcome was of that case, but it was done so many years ago to puncture directly the cavernous sinus to place a detachable balloon. Thank you. It was just.
Thanks, Dodi. The more things about on the chat. So, Arun was asking about superior petrosal sinus option, like yet another option to get in there. There's some, not as common as the IPS, right? But that can work as well if there is an SPS or suggestion of one. Anything else? I don't know, Arun, if you want to add anything. Okay. Let's see. Any other questions or comments? Dr. Yang and Wei, thank you very much for this case. A lot to discuss, like very interesting, very important. Maybe we should have, we can have, there's so much we can talk about, right? We can have like a presentation on direct transorbital access maybe next time or something, because I think that's, so like we can get into that more. There was a question earlier. Someone asked a question about microcatheter injections like if you're doing a microdyna, like here. I don't know if Renee is if Renee is here, but if you're doing a microdyna or microvase or whatever, what any pointers at what do you do with like how do you do this?
Okay,
By hand, by
so
machine, whatever.
yeah, very good questions, and I'd like to share just one how the microdynar or convimsity with selective injections of ascending pharyngeal artery. Okay, do you do you see this one?
No. We see right ascending pharyngeal, we see like a red mouse.
Okay, right now. So this is the AP view. It apparently that was most of the young colleagues mentioned. Oh, this is the.
So we don't see Michi here.
Okay,
We see like a black screen.
black
The
screen.
now
Okay.
we see. I see now.
Now you see, and I will move to the. Okay, so how can I made it? Okay, I will maybe. Then now
Okay.
now you don't see.
Now it's weird. Now we don't see. We saw like some message that you clicked on and then it's black.
Okay, so I will change my way of the share application window desktop one.
I will say this about the previous case that like as much as we are talking about all these other accesses that you can do this minimally invasively, transorbital, trans whatever, and it's minimally invasive, of course, is better, I think, for most cases. But to have experience with doing this kind of operation is also important, right? Like every way is important.
You see this angio?
Yes.
Yeah, we do.
Okay. So the young colleague there, our colleagues there mentioned that this is a bilateral multiple shunt, something like that. But if you do that super selective ascending pharyngeal AP view, this is exactly midline. Therefore, it is very important to put the head of the patient on the right way, not tilted, not rotated, just straight off way to define that the midline precisely. Then you can appreciate this kind of shunt or this terminal feeder is accumulating just 1 point on the right lateral view. And this is what you want to see. I don't know, it's moving or not moving. Wait. Yeah.
Yeah, we can see.
But the movie doesn't move. Wait. Here. It's the same case, selective ascending pharyngeal injections, and the very thin 0.2 millimeter thickness of the multiple intensive planes, and the terminal feeder intraosseous, and here is already the venous pouch is here, and this is still intraosseous through the posterior clinoid process, intercavernous channel, and here is the lateral view, certainly that the intraosseous arterial supply as well as the meningeal supply convergence into the one single point, which is the shunt point. It's here. And this is another view, like a bird view. And magnified, you see that the still same contralateral ascending pharyngeal injection, showing that all the terminal feeder accumulating suddenly the density of the contrast is changing, and the venous pouch in the anterolateral compartment of the cavernous sinus. But here is the posterior clinoid process, and shunt point is still strictly localized on the left side of the posterior clinoid process, which usually they say intercavernous channel. Here is the same. So if you can identify very precisely with the selective injections with the ascending pharyngeal artery, and this is the ipsilateral ascending pharyngeal arterial system, you see that the terminal feeder is here. So the diagnostic angiography is much more important than which type of microcatheter do you take, and transarterial or transvenous, it doesn't matter for me. For me, most important thing is how can we understanding of microarterial structure in the level of the AV shunt. Where is locating? Where is the terminal feeder? Where is the cavernous channel? Where is the cavernous branch from the ascending pharyngeal, inferior lateral trunk, and so on? Those of things is just short message what I did, and in the end, I hope it works. Yeah, this is a bilateral. I love bilateral, not external carotid, but ascending pharyngeal bilateral injection. Really, you can appreciate. You see that the whole the angular structure, of course, in the maximum, and you have a so-called fusion imagings independently, right and left, and the fuse. But in my institute, I love to do bilateral simultaneous injection of ascending pharyngeal artery. The whole thing is clear, so all the people easily to understand where is the target region. And yeah, here it's the same system, but another view more up. We intentionally get the acquisition of the late venous phase in relation with the fistulas, and here is the deep venous systems, and some of the reflux into the peduncular venous systems and the anterior pontine and transverse pontine veins and lateral pontomesencephalic veins, continuation to the spinal canal. And here is the same thing. So this is just I wanted to show with you. Thank you.
Yes, beautiful. Thank you very much. Beautiful, really.
Yeah. So Rupa was asking, it's fantastic. And again, like to emphasize that this starts with general anesthesia. Like you basically can't do this without general anesthesia, especially in the external injections. It hurts, even very cooperative people, probably most people will move. So we need GA and paralysis and all these things. Now, Rupa was asking, what's the rate of the micro injection, pressure injection, like any comments
Yeah,
here
thank you
about
very much. Very good questions. If you do the like a Tracker 10 or a marathon or a magic catheter, whatever, I use only 3 cc hand injection because a microcatheter is not affordable to connect with our auto injector. But on that ascending pharyngeal injection, we put the 4 French catheter, which you can connect with automated injector, and we have a dual injector we have, so you can have a bilateral, even dual impulse with hand injections. So 3 simultaneous injections also available. If you have another colleagues that the 4 simultaneous injection is also available in case if you need, of course. Then the injection ratio is if you use a 4 French catheter around 2 cc per second and totally around 18 or 20 cc or 0.5, 0.6 cc, then 20 second is also available, which means totally 12 cc.
You have a similar protocol. I think from the 2D injections, you kind of get the sense of what the rate should be. And sometimes it's hand, sometimes there's no single rate, right? Depends. It could be hand. Let's see. Any other questions or comments? If not, it's been a fantastic session. I think we saw some really awesome cases today and good participation. So thank you all very, very much. Really appreciate everybody coming and showing and presenting. Thank you all.
Very much.
I think we should continue to do this a little. I think this time we'll find it, but it looks like this time works good. Works well. I think more people can join, and that's very, very important. So we'll probably, 6 a.m. Yes, Sophia, 6 a.m. on the West Coast. Yeah,
2
we've
a.m.
tried
2 a.m.
noon.
in Japan.
It's so hard to, they are recorded, so maybe we'll vary the time, but it is hard. We haven't solved the problem that the world is round. So the time that's remains to be figured out. Okay. Anybody else? Wishing everybody, happy holidays and happy new year. And I hope so. We'll again a plug for the April. In April, there's the in-person banana, and then we'll continue, of course, with the online bananas as well. So that will continue.
Thank you,
Okay.
Maxim, so much. Thank you.
Thank you all. Thank you. So good to see you all. Thank you. Bye-bye.